go into that. I was just going to talk about planks, but now I've been educated about the A&P I test. So work on your planks. I was going to say something from yesterday. Oh, peripheral versus a dermatome. You know, people ask me about that. And I thought, well, how do you say that more simply? How do you say the difference between a dermatome and a peripheral nerve field without being so confusing like the big? How about this? If I have a patient who has a area of loss of sensation like on their arm, but it does not include the whole dermatome, I know a fact right now. I know that the damage they have is not at the spinal cord level. It's out here in the periphery. You've severed a peripheral nerve or you've crushed a peripheral nerve because that provides sensation to an overlapping area of dermatomes. But that tells us the difference between, is this a peripheral nerve problem or is this a spinal nerve problem? Does that make more sense? And that's all because it's before or after the plexus. But a dermatomal pattern will always be a problem at the spinal nerve or spinal cord. Central versus peripheral nervous system. That's why we looked at it. Anyway, I don't know if you still had that question, but others did. We left off here, we looked at naming tracks, but here's integration and response. So as we start to look at these, we say sensory systems. We're repeating what we already know. Sensory systems, input to the central nervous system. Once it gets in there, you have interneurons, neurons that connect to neurons. And they integrate by deciding where it's going to go to. And then you have responses. That would be your motor nerves that give out responses, whether that's somatic motor nerves, that's autonomic motor nerves, either one. And then the cerebral cortex is what's going to play that role in voluntary muscular movements. So if you didn't catch the last part of that slide, you're saying that there's sensory always coming in. There's autonomic sensory, there's somatic sensory, and there's interneurons and nuclei that are making changes or receiving that and then making decisions. So if you're in the brain stem, like the breathing and heart rate, you're not aware of that. But if it's skeletal and it reached the cortex, you will be. It's the difference between a sensation and a perception. Sensations occur all the time at all levels. That's the sensory coming in. But you don't have perception or awareness of that sensation until it reaches the cerebral cortex. We'll talk more about that under some of our special senses stuff. Right now, we're talking pathways. If a pathway travels out down the spinal cord or where it came from, if it's a direct pathway, that means it came from the cerebral cortex. If it's an indirect pathway, it originated in the brainstem. So we're looking at a motor output. Anything that you're not constantly aware of is an indirect pathway. And then we have to throw in there reflexes. So a reflex will occur to whatever given stimulus, whether that's hot, cold, hitting yourself with a reflex hammer. Reflexes you're born with are called innate. So we have reflexes, newborns have reflexes that they are born with. Some of them go away, some don't. Some we have for life and we can test them. And they also can be learned. I guess if I don't know, you learn a reflex, I won't be funny like that. I was going to joke, I won't. People, types of reflexes, I'm going to stop. Types of reflexes are based on the side of integration of the stimuli. Meaning if it's a spinal reflex, that's occurring, of course, in the spinal cord gray matter. If it's a cranial reflex, integration is occurring in the brain stem. Our cranial nerves come off of the brain stem. So it's a cranial reflex. The reflex associated with cranial nerves. So it's going to be, most of those would probably be, not all, but more autonomic reflex. There's somatic reflexes, autonomic. But anyway, that's a reflex. Either it occurs in the spinal cord or it occurs in the cranial area, brainstem. If you look at the types of muscles we're talking about, we know, once again, I've repeated it too many times, somatic, skeletal muscle, visceral. The reason I repeated this and brought it up is because now we're talking not just what is controlling, but we're talking about the reflex. We have somatic reflexes, like you touch something hot, your hand comes away, that's a somatic reflex. You cause the muscle to move. But like in your stomach, we have reflexes also. Visceral reflexes, cardiac muscle, different glands respond to this. And we're not aware of these. And when we compare them, we test reflexes. But we can't test visceral reflexes. Well, we can shine a light in your pupil and see that they both constrict at the same time. That's a visceral reflex. But we don't generally try to test them in clinic because there's no real clinical value we could get out of it. We can't really test them like we can somatic reflexes, meaning taking your reflex hammer and hitting on people. So reflexes are going to follow what's called an arc pathway, and that does not mean that your central nervous system isn't aware of it. So we know we can map pathways. A reflex, I'm going to show you reflexes that occur at the spinal cord, though they occur higher up. But we're going to focus in on the spinal cord reflexes. So at every given level of the spinal cord, there exists the potential for a reflex arc. But the reflex will talk to the central nervous system, but it's going to happen first. So I'm going to keep using the analogy of putting your hand on a hot plate. And so if you reach down and put your hand, you're not looking, you put your hand on a hot plate, your hand will move away, right? Right away. That's the reflex. It got your hand away from the pain. But you're aware of that. We say it right away, right? Oh, that's hot. So we know if we have perception, it went to the cerebral cortex. Right? But I guarantee if you were to slow-mo it frame by frame and you could think about when you realized that if you could do that, or if we put a probe in your cortex, there would be a delay between when the reflex occurred and when it got to your cortex. Now that's a very short time frame, but I'm trying to help you understand it. It shoots that up to the cerebral cortex to know what's going on too. Dang, that's hot. Right? But you already moved your hand. So the reflex protects you. But they're also diagnostic. If your reflexes are not what we expect they should be, you have some type of nervous disorder, right? Problem along the arc. So here's the components of a reflex arc. Sensory receptors, sensory neuron. So you're going to have some type of receptor out there that has to pick up whether that's hot, cold, pain. There's a receptor. Then you have a neuron that's carrying it to the central nervous system. It gets integrated at an integrating center. Then you have a motor response or a motor neuron that goes back out, and it talks to the effector. The effector is going to be the organ. Always, not everybody does, but I find that saying effector, I'm like, well, it doesn't make sense to me the way that word sounds. The effector is the actual visceral organ. So if I have a change that occurs from a reflex to change my heart rate, the effector would be the heart. What's actually physically doing the change, not what talked to it. Because I always, if y'all probably don't follow where I'm going, but in my East Texas mind, I'm like sensory receptor, sensory neuron, integrating center. I got all that motor neuron. Then I get to effector, and I'm like, well, we're sending motor neurons to the heart. Shouldn't we call it the effectee? Right? See, don't do that. I shouldn't even say it. It's the effector. It's what physically does the change. All right, so let's walk through this. We have a dendrite or some type of sensory structure out here that's going to pick up the fact that you got stepped on a tack or whatever it might be. That stimulus will cause that receptor to produce what's called a receptor potential or a generator potential. I don't want you to worry about the difference between those just yet. Just telling you it will. It's going to make a potential, which means that we're going to try and cause an action potential. So that we can, let's just say that we did at this point. We caused an action potential to send a nerve impulse, and that's going to travel up the sensory neuron. And we're looking at a somatic system here. And all sensory neurons, before they go into the spinal cord, have their cell body in the dorsal root ganglion. And it will travel in. This is a simple reflex arc. That little lobster-looking area means you're synapsing with this interneuron, and then it will synapse directly with the motor neuron, go out and tell the skeletal muscle to move. That's a reflex arc. When you look at the gray matter in the central nervous system, because it's all the neurons, they call that the integrating centers. So the simplest reflex would be what's called a monosynaptic reflex. In a monosynaptic reflex, we would have one sensory neuron talking directly to one motor neuron. And that's not really depicted here because we don't normally see that. Most are polysynaptic. So I'll draw on here. If it was a monosynaptic reflex, this sensory neuron that's coming in would come all the way over here and synapse directly. In other words, there would be no interneuron. But we don't generally see that. Almost all of them are polysynaptic. I'll show you one here in a second that is monosynaptic, and that's about the only one we worry about. And then you get to the integrating. I've talked through the whole slide without advancing. So you get to your integrating neuron. It passes it on to the motor neuron that will respond. The motor neuron goes out to the effector, in this case, some type of skeletal muscle. If it was an autonomic reflex arc, it would talk to visceral muscle. When we get to the autonomic nervous system, we'll see that we'll discuss the autonomic reflex arc, but it's exactly the same as the somatic. So just controlling different things. All right, so let's put this in practice. Stretch reflex. We've all seen somebody take a reflex hammer, hit on a tendon. The knee, best example, hit on your patellar tendon there, cause your leg to extend out. Okay, that's a reflex that we can test. That's called the stretch reflex or patellar reflex. So we're going to look at why does this occur, and it's because we're controlling muscle length by causing contraction. So if you look at this area here, we don't want the muscle to overstretch. So a stretch reflex occurs because inside of the muscle, you have many of these muscle spindles. Muscle spindles are receptors for sensing what type of stretch the muscle has. So if the muscle is stretched too far, the spindles will pick that up. And a reflex will cause the motor neurons to be activated that cause the muscle to contract. So if you're talking about being on a stretch, like your bicep when you curl is contracted. But if you put that muscle on a stretch, right, and it's too much stretch, then a reflex will occur that says, hey, let's protect this muscle. We don't want it to stretch that far, and it will cause it to contract. We're starting and we're building. We're going to talk about how that all gets balanced. So the brain is going to set the spindle basically tone and say how much will you contract if those are stimulated. Like different people, if you hit a patellar tendon, some people like the knee goes flying or leg goes flying out. Right? You hit the patellar tendon and they're way out. Other people you're like, you ever had those people trying to get them to relax? Some people's reflexes aren't diminished, but they're just not as apparent than others, and they don't react as. There's a range, let's say. Now I will give you a point here. Whoever your exam partner is in PA school, if they don't have good reflexes, I'd find you somebody else. Because they're going to get you. They're going to get you because I can elicit a reflex in most people, and I do a lot of them by feel versus seeing it if you can't. But when you're going through that whole person exam for testing, and you got the wrong partner, I'm being completely funny here. You got the wrong partner, they don't know how to play the game right. If I'm in the lab practicing, trying to get your reflex, I'm fine with you saying that get it, until you figure out how to hit it just right and get that. If I'm on the exam, my partner knows that if I even get close to him, like the air brushes by his head, every reflex I test, I will get first time. Boom. Boom. Just telling you. I mean, you'll see those people though. They'll be sitting there during the exam. You look over at somebody else doing their test, or you're waiting, and their partner's just sitting there. Even as a grader, I'm like, "You gonna help them out here?" All right. That's completely true. Reciprocal innervation. People try to make this like harder than it has to be, and it's because you're hearing it the first time a lot of times. But let's talk generalities first. If I have biceps and triceps, everybody does. Right? If my biceps contracts, what do my triceps have to do? Relax. So if I'm causing my bicep to contract, I'm stimulating that, which means I'm sending basically excitatory signals to the muscle cells to cause an action potential to cause a contraction. But I'm also sending inhibitory signals to the muscles in my tricep to tell them to relax. If not, you would play muscle, the opposite, antagonistic muscle every time. So this is a balance that goes on between them. And brain's setting the tone for this, but one has to give. Antagonist contracts and antagonist will have to relax, or the motion can't occur. We have to look at how this is set up. Now, I don't want you drawing. We're going to look at several pictures of a stretch reflex and a tendon reflex, and I do not want you tracing these out and drawing them out other than to help visualize it. And I'm not going to ask you to label this. I'm just going to show you what occurs. Is if they're using quadriceps here. So our quadriceps, these are muscle spindles. And then you have muscle spindles, which are a type of receptor, sensory receptor. And so that muscle gets put on as quick stretch. You can either stretch the muscle too much, or if you hit it with a reflex hammer, what you're actually doing is causing a very quick stretch on that muscle. Because if I hit this tendon, I'm kind of pulling it this way, right? And so that puts that muscle on a quick kind of a twitch type stretch. And that spindle will pick that up. And it doesn't know how much you intend to do that. It just knows it was fast. So it tries to tighten up. It will contract. So the way it's going to do that is that signal will be sent along a sensory neuron up through the dorsal root ganglion. Right? It will synapse. Now, stretch reflexes have two parts. They have the sensory neuron talking directly to the motor neuron, and that will go back out to that same muscle and say, contract. That's the part we just talked about. So in that case, that's the one real example of a monosynaptic reflex that we would talk about. The stretch reflex, it's monosynaptic. Most are poly. But polysynaptic reflex actually occurs at the same time as that sensory neuron that came in actually talked to this integrating neuron and went over here, and we use a dotted line. Dotted line represents that you're inhibiting. So they're going to go down here and cause the antagonistic muscles, in this case your hamstrings, to relax so that your leg can come forward. All of that occurs split second, we know, at the same time. So that's a muscle. So I want you to think of this. The muscle wants to protect itself. And the reflex is how it's doing that. I talk about it that way, even though we picture all reflexes as like touching a hot plate. But even when you touch a hot plate, when those muscles are forced to contract and relax, it is protecting itself as part of it. And there's a difference between saying we're going to hit it with a hammer and test it so the muscle gets stretched really quick and it wants to protect itself so it'll set off this reflex. But the reflex also occurs with something hot. I'm going to explain why I'm saying that because we're going to tendon reflex. So all muscles have tendons that attach it to bones. Well, the tendon doesn't trust the muscle to do the right thing all the time. right? If the muscle contracts so tight, excessively tight, that it had the strength to pull the tendon off the bones. Can that occur?
Yeah.
You betcha. I mean, probably somebody in here that outlifted and had a bicep tendon come loose or something, you know. They can, so the muscle has that ability. So the tendon can't rely on the muscle, right? Just like me, I don't trust many people. So the tendon says, I'm gonna go out and buy my own receptors to tell me if I have too much tension. So the tendon has a Golgi tendon organ that measures, it's a sensory organ that measures how much tension is on the tendon. So if I know I'm not going straight by the slide stuff, but it's easier just to talk about. If I'm pulling on a muscle, like, I like to use the leg because that's all the pictures, but if I'm pulling on my bicep and I start pulling on the tendon that's connecting it, this muscle is contracting and I'm trying to pull this way, pulling, and the tendon has a Golgi tendon organ in it that can measure that tension. If it becomes too much or too quick, that tendon will say, well, what I meant to do is phrase it. What does the tendon need to cause? But of which muscle? The same muscle that's causing the problem. That's why I said it doesn't trust the muscle. Right? So the tendon is going to measure the pressure that same muscle is pulling on it. You say it that way, people understand, but if you just read the slides, you get a little confused. So it operates a feedback mechanism to control muscle tension of the same muscle it's part of, right? So those Golgi tendon organs, they can be activated by stretching the tendon. An inhibitory neuron will also be stimulated in this case. And then the motor neuron gets hyperpolarized to relax the muscles. I'll show you what I mean, the difference. It still has what's called reciprocal. I didn't mention that when you have a motor response to one side and the opposite response to the other, that's called reciprocal innervation. Antagonist, agonist actions. So here's your tendon reflex. Now it looks the same, but it's a little different because here we have a tendon of our quadricep that has a sensor that says, hey, I'm being stretched too much. So in this case, the quadriceps will be contracted. So it's going to send a signal over here. I'm not going to talk to polymonosynaptic stuff right now. And it's going to send the inhibitory signal back to the same muscle to say, now relax. Now you're putting too much tension on me. Then it also sends a reciprocal innervation over here to this antagonistic muscle. In this case, if we just caused our quadriceps to relax, another way that we can take tension off that tendon will antagonistically will cause the hamstrings to contract. Sorry. We're doing both opposite actions of a stretch reflex. So when you put all that together and you start trying to make sense of it, just think back to if there's the muscle or the tendon. Tendon doesn't want too much tension. The muscle doesn't want too much stretch. Right? Muscle doesn't care how much it's contracted. Right? It cares whether it's on an extension. So if they're both measuring that at the same time, that means it's a give and take situation. So we're studying it as two different things, but both of these, are they both protecting the same muscle and tendon? Yes. And so you say, well, how can these be going on at the same time? Because we're thinking about testing it or we're thinking about damaging it. But if you just think in simple terms of like lifting things, these have to occur at the same time. The tendon Golgi organ protects the tendon, the muscle spindles protect the muscle, and there's a balancing act that occurs between them that cause all these reflexes. Hopefully I'm not saying this too much. That's occurring all the time. But we study them like we're going to test it. Does that make sense? They're both protecting muscle, but we're going to try and test this. Because we know if there's a problem with it, we can find out they have different types of neurological disorders. Yes?
So with that reflex, can you ignore that reflex, and that's what leads to like torn tendons, such as like tearing your distal biceps or your hamstring tendon?
You're not really going to ignore the reflex, but I mean, sure, you could overcome that by just continuing to, right? In other words, that reflex is not strong enough to overpower the fact that you weren't prepared to, do 300-pound curls. Right? You can overcome it, and it cause damage for sure. But it will try. If you were to look at while you're doing that, they'll be sending signals. You just decided you're going to overpower that and tear it. If not, you'd see people in the gym all the time, right? Trying to put up too much, and you'd just be dropping all the time. Or it tore. All right. That'd be funny videos. I'd look at those on Instagram. There are some funny gym ones out there. I like the ones where they fall off the back of the treadmill. Great. They take out like 4 or 5 people who try to help them. That one's great. Okay. Flexor and cross extensor reflexes. Last part of these reflexes. I described this to you yesterday though. When you hear flexor withdraw reflex, you need to think pain. Right? It's something quick that happens to avoid pain. Nociception or nociceptors are pain receptors. That may be a new word to some of y'all. Nociception is pain reception. Okay, so we're gonna touch hot plate, and actually, what does occur, is anytime you touch something hot, painful, whether it's you step on a tack, whether you put your hand on something hot, the first response is going to be the flexor withdrawal. Get away from that. Same thing. In other words, I just caused my bicep and other muscles, shoulder, different things to contract really quickly to get off of that. Same thing would happen if you step on a tack. You're going to flex your knee up to get off of that. So they call it flexor withdrawal. The cross extensor reflex is the fact that there is reciprocal innervation, and then there's cross extensor reflex. And hear me on this for a second. Is reciprocal innervation is going to occur in antagonistic muscles. The cross extensor reflex is going to cross over to the other side of the spinal cord. Because if you watch the leg's the best. I don't have to say watch somebody, but if you did watch somebody put their hand on a hot plate, when you have the flexor withdrawal, the other hand's going to come up. So if you go out, there's funny videos all over Instagram and stuff, right? So whatever social media you use, I'm getting soon enough, no one will be using Instagram, and I still will be. And y'all be making next class will be making fun of me because it's so yesterday. It's like MySpace. Anybody ever have MySpace? Man, they just lost the battle, didn't they? They're still out there, but they were the original Facebook. They got walked all over. Anyway, flexor withdrawal. You put your hand down, everything on this side flexes, everything on this side extends. The best example though is walking and stepping on a tack or something, because if your leg comes up and this side doesn't go into extension, you're going to drop. Okay. That's the cross extensor reflex. And this is what I just explained this. This is definitely why I was saying, do not, put you something there, do not draw this out. Don't even worry about this picture again. Really, because I'm just using it to show you how if you lift off a tack, but here's the actual whole process. Same thing. Don't learn this picture. Just I just went here to show you that when you stepped on this tack, it sent a sensory signal into here, and it went to cause deflection, but it also came over here, decussated over to the other side and caused extension. If you got that simple part of it, don't worry about the rest of it. You'll just confuse yourself trying to map this all out. Now, we're going to map the sympathetic nervous system, so don't think that when we get there. But here, I'm just trying to make the point. The other side has to extend. Then our last kind of reflex we're going to look at is Babinski, because you always hear that one. Babinski, it's where you take, like in this case, we're using a reflex hammer. You run it up the bottom, plantar side, lateral part of your sole, And normally, if you're an adult, you're older than a year and a half old, your toes should go down. I'm not taking my shoes off. All your toes, when you stroke the lateral side by your little pinky toe, you stroke that, they should go down. If the big toe fans, if it fans up the great toe, or even all the others, you can't have fanning of all the digits, but if that great toe goes up, that is a positive Levinsky sign, which is illustration B there, that tells you there's something wrong if it's a child greater than a year and a half old. Reason for that, you'll learn this in physical exam, is that up until about a year and a half old, your corticospinal tracts are still, they're not mature yet, they're still myelinating, and so things don't travel as fast as they should. And so if you're a child under a year and a half old, your toe may still point up. But for most of the people you'll ever examine, curling down means no Babinski. They don't have a problem. If they do, they have a problem with their corticospinal tract. And then it's time to punt. For most of us. Y'all know what punting means? I'm sorry, I'm talking like everybody's been around medicine growth. When a PA says they're going to punt, it means we're writing a referral. We're getting them out of our office. So sometimes I can decide in the first 2 minutes of when I'm punting and how far I'm going to punt it. All right. Last part here, diagnostic value. We're not physical exam just yet. You're starting to learn some of that this semester. Reflexes can tell us a lot, though, because they're predictable. They're repeatable. If it's a somatic reflex, we can test it very easily. And so if you have a problem with a reflex, diminished, hyporeflexive, that means you have damage or disease somewhere along that reflex arc. So we use somatic reflexes to test them and figure out if we have a problem with that. Autonomic reflexes we do not use, other than the pupillary light reflex. So there's no clinical correlation to use with those. And here's all I'm going to give you on them. We're not getting into it any more than this. You will, guarantee you will before you leave this building. Hyperactive reflexes suggest central nervous system disease. When you have a decreased reflexes or hypoactive reflexes, means you have damage to relevant spinal areas, diseases of muscles, disease of the neuromuscular junction, loss of sensation. You can't feel it. The sensory can't work. So hyperactive, CNS. Hypoactive, PNS. Out at the neuromuscular junction or somewhere there's a problem. It's a good delineator of that. And then you got some definitions. I mean, you know I'm going to throw in there all the names of different spinal cord injuries and what they consist of. Monopedic, paraplegic. Actually, the book's old. We do not use, society does, but in spinal cord injury, you don't, we say tetraplegia, not quadriplegia. But there's a lot of naming conventions used in spinal cord that got consolidated not that long ago comparatively to where the whole world wants to use the same grading criteria. They created this thing called the Asia scale and tetraplegia. Anyway. Saying that because like you go into the VA system for billing and you try to do an ICD-10 code, some of y'all probably go, what the hell are they talking? Billing codes. And you look for quadriplegia. It's hard enough to find anything in that system anyway, but you're going to need to type in tetraplegia or it won't come up. Y'all know what ICD codes are? I know some of y'all obviously do. What's that? Yeah, much better. 10 sucks. 10 sucks. They try, for people who've never heard of those, they're like, what the hell are y'all talking about? But if you don't realize this, nowadays, the bean counters have pushed it down to the providers to make you, just like as a civilian now, every 2 weeks, I got to put in my own hours. Even though I'm here the same hours every week, I got to do a little thing. If I don't put it in, I don't get paid. I'm fine with that. That's fine. That's fair enough. Same thing as a provider nowadays, especially in the civilian world. You have to go through and find the ICD-10 code. That's the new version, and it's been out a while. And you got to find every diagnosis you're giving them, and you got to find the right number. It's very complicated sometimes unless you're using them over and over. So I kept a cheat sheet of the ones I use next to them. In other words, you got to make sure your patient gets billed right so everybody gets paid. Somebody does check that. I found out by not doing it right. But, yeah, I hate ICD codes. I'd rather be deployed in the middle of nowhere and treat people. That's better than being in clinic. All right. It's just like they took away the ability to, it used to be, when they created graphical user interfaces to do patient charts, I used to write my own templates. So it made my notes easier because it would pre-fill in. I could build a template, and if I pulled up a patient, it would pre-fill in everything I wanted it to. And they do that now, but now they don't let the individual providers fill it out. They do like a committee and decide what they want in this template. That's the only template you can use. I hate that. I hate that. Because I'm a little bit OCD. I can do it my way. Because your way is probably not good. Not y'all. Never talking about y'all. Remember that. Everybody thinks they're right in this world. You ever notice that? Somebody's got to be wrong. Could be me. Probably is me. I don't know. Okay. I'm just talking because we're switching gears to talk about spinal cord, autonomic nervous system. The autonomic nervous system is kind of a beast to some people. But luckily for you, you got somebody who understands it really well. And the better I understand it, the better I can help you understand it and let you know what I expect you to know. So no worries. Let's start out. Remember, this is a whole separate section before I got it all combined. The autonomic nervous system, we know, is concerned with visceral actions. So we're going to have visceral neurons, visceral sensory neurons, visceral motor neurons, afferent, efferent. None of that's changed. That's just like the somatic system. And we know the big difference is we're controlling things like the heart that are autonomic. We still have reflexes. And the autonomic centers are going to be found in the brainstem area. That's going to include our hypothalamus and brainstem. I know I was trying not to say hypothalamus today, but I had to. It is part of the regulators. Go all the way back to the beginning. What controls homeostasis? The endocrine system. Now y'all know why I don't like it. No, y'all did. It looked like y'all did really well. I don't have to work today. Y'all were talking when I came back in the room really loudly. That's how I know people's feelings were within giving instructions and stuff. Whether I need to like shut it down early or just not talk. Anyway, hypothalamus, part of the endocrine system. The nervous system also helps to regulate that. So we're looking at reflexes, but I put up a different chart of the nervous system. It's just like the one I had before. It's just structured differently because we still have our somatic nervous system, the autonomic system, and then the enteric. All of these do talk to the central nervous system, somatic. Right, motor neurons leave there and talk to skeletal muscle. Autonomic motor neurons go to smooth muscle and cardiac glands. And enteric nervous system, motor neurons go to the GI system, basically, and any supporting structures there. Where we're going to focus a lot of our talk here in a few minutes is right here. Sympathetic and parasympathetic divisions. That's really what most of this talk is going to be about. As you look at the autonomic nervous system and its receptors, in a somatic system, we looked at receptors being like muscle spindles, tendon Golgi organs, but we have interoreceptors inside. Interoreceptors, like chemoreceptors monitoring blood pressure, or mechanoreceptors. There are a lot of different types of mechanoreceptors. Like when your urine fills up in your bladder, it puts a stretch on the bladder wall. That's a mechanoreceptor. Walls of blood vessels, different organs can detect the amount of stretch put on them. That sends info to the autonomic nervous system. And it's like stool pushing into the rectal vault will stretch that out, and it triggers reflexes for I need to go use the bathroom, that kind of stuff. So they're constantly perceived, but we don't, or sorry, they're not consciously perceived normally. If an autonomic reflex or an autonomic signal that we don't normally perceive is very, very, very intense, we can start to perceive that. I'll explain that in a minute. Yeah.
What's the difference between a mechanoreceptor and a baroreceptor?
Nothing.
Okay.
I mean, just two different things.
I just didn't know if there was something different.
No, it's no different than them going, well, we're mechanoreceptor and an interoreceptor. I would call a baroreceptor a type of mechanoreceptor. So threw me off for a second.
I thought it was a silly question,
I was expecting a real deep thought on it. What's he gonna ask me? No, I didn't mean I was putting you down. Good question. I didn't mean it that way at all. I just realized I said that and did that. All questions are good. When I said a deep question, I meant like one that I couldn't answer or something. Like, so I had to put on my thinking cap and go, let's see about that. Kidding. Keep asking questions. I won't mess with everybody else. What was my point? Do you feel the vessels in your heart right now? No. Some of y'all do? No, we don't. We don't know what's going on there. During a heart attack, when they're blocked, do they feel that eventually? Yes. That's the whole point of the bottom of the slide. That is a visceral, right, reaction. So if you have a sensation in the autonomic nervous system, can rise to the level of perception that you're aware of it, but it would have to be very intense, like you're having a heart attack. Eventually, you may become aware of that. But before that, I don't want to get into it. Sorry. Regulation of visceral activities. When you look at autonomic visceral activities, once again, just like somatic, it's still going to be exciting or inhibiting activities in their effector tissues. We've just changed what type of tissue it is versus muscle. Okay. One difference, though, is when you look at skeletal muscle versus autonomic visceral muscle, my autonomic system often has an intrinsic function. So if you were to sever the connection, all connection of your bowels, your intestines, from the central nervous system, they would still function. They just would not function very well, like I talked about with spinal cord patients. Same thing with the heart. Right? You could sever that connection to the central nervous system, the heart won't function as well either. Right? But they do have that intrinsic function if the nerve supply is damaged. This is where we're going to start getting into detail. We're going to look at these pathways. And when we looked at motor pathways for the somatic system, we learned that somatic motor neurons are in the, tell me if I'm wrong, anterior gray horn. In a somatic system, you have one motor neuron that goes all the way out to its effector, which in that case would be a skeletal muscle. And I'll mention here, just for the sake of it, the only neurotransmitter used at skeletal muscles is acetylcholine. We'll come back to that. You'll know why I said that later. Okay, we want to focus in here on this autonomic nervous system, because the autonomic nervous system consists of 2 motor neurons. So when you look at the sympathetic or the parasympathetic system, these motor neurons side, there will be 2 neurons. So autonomic motor neurons come out of the lateral gray horns of the spinal cord. So you're going to have 1 motor neuron that is here, and then you're going to have a second motor neuron that is here. That's the big difference. 1 versus 2. It's going to make a big difference, though. When we look at the first, now just switch, forget about somatic, and let's look at autonomic. When you look at and name these, the first neuron in the autonomic nervous system is called the preganglionic. And its cell body is in the central nervous system. I'm talking slower now because we're going to walk all the way from here out to our effectors as we go through here in the next hour. But if you get the small parts as I'm going through. Okay, yesterday we learned that autonomic motor neurons are found in the lateral gray horns, correct? Man, that means that their cell body is there. Right? The neuron cell body is there. The fibers come out of that. So that's called the preganglionic neurons. So you would say preganglionic autonomic motor neurons of the preganglionic, their cell body is going to be in the spinal cord, specifically in the lateral gray horn. It leaves there, goes out of the spinal cord, and it goes to a ganglion. That's called an autonomic ganglion. Now, forget autonomic, just ganglion. What's the definition of a ganglion? Yeah, a collection of neuronal cell bodies in the peripheral nervous system. That's the exact definition. So that ganglion is full of cell bodies. And what cell bodies are they? The postganglionic neurons. So I need to switch slides, I guess. But we're going to call them postganglionic because they're after the ganglion. So an autonomic nervous system has a pre and a postganglionic neuron. This means it's before or after the ganglion. All right, so if we looked at the neurotransmitters in somatic system, we said it's only acetylcholine. The difference with the autonomic nervous system is that it can use acetylcholine or norepinephrine. We're going to see the big change that I'll come back to is all somatic motor neurons use acetylcholine as their neurotransmitter. I'm going to say it and you'll get it later. All preganglionic axons of the autonomic nervous system release acetylcholine. Where the difference is autonomic nervous system, the postganglionic neurons will release acetylcholine or norepinephrine, depending on the site. That's the opener. Now, if you look at the sympathetic and parasympathetic systems, they're said to have dual innervation. Dual innervation means that most target organs or tissues of the autonomic nervous system receive both sympathetic input and parasympathetic input. That's called dual innervation. And it's generally like taking your foot on and off the gas. So you put your foot down on the gas, that's generally the sympathetic system. Take your foot off the gas, that's the parasympathetic system. But if you drive like my wife on the highway, that's constant. Like, will you put it on cruise or keep your foot steady? You ever drive with those people? Is it just me again that it bothers? You have? Thank you. No, go ahead.
Well, it goes back to those motor innovation. In the preganglionic neuron is myelinated, like on the postganglionic is unmyelinated. Is there a reason why?
Why do you want to pick on me for not mentioning stuff as we go through?
I've been raising my hand, you just didn't know.
Oh. See, that's a great comeback. That's somebody that doesn't complain later that you messed with them because they messed with you right back. That's what I was talking about at the beginning. I like that. Put me in my place right away. I like that. All pre-ganglionic axons are myelinated. All post-ganglionic axons are unmyelinated. All somatic motor neurons axons are myelinated. Why is that? I don't know, but I do know it's much faster to be myelinated. It's one of those things I like to say, that's what they noticed. But I talk about that. I left it alone on purpose, but I talk about that when we look at the speed of how the sympathetic and parasympathetic systems affect things. But for now, it's just a fact that all post-ganglionics are unmyelinated. That's one of those we like to postulate. Why? Well, why is it? Why is it? Oh, that's just the way it is. All right. That was a great interaction. She was just trying to slow me down to get to the break. This hour has gone by longer than normal. I don't know what this is. For y'all too? It seems like it's taking a long time. I know, we're not there yet though. I got a minute. Okay, no, divisions of A&S. Let's do these. We got 2 slides, and then we'll take a break. Okay, as a general rule, when you look at nerve impulse from the autonomic nervous system, generally it's going to excite, and others are going to inhibit, depending upon whether you're talking sympathetic or parasympathetic systems. But also, this is the confusing part before the break, is when you look at heart rate, we would think fight or flight, heart rate, sympathetic system, that we start running, a heart rate's going to be increased to get away from the saber-toothed tiger. Right? So we often think, we're taught in like emergency medicine things, fight or flight. Everything's going full bore, we're gearing up. Right? But when you get into class and you start really thinking about it, not everything's getting geared up. We don't need everything geared up. So if you look at what is, when you look, I'm going to get back. When you look at heart rate, sympathetic division puts it on the gas. Parasympathetic decreases that. But you look at the muscular movements of the GI tract, they're slowed by sympathetic input and increased by parasympathetic. Right? So your sympathetic system activates because that saber-toothed tiger's there. It throws your heart rate through the roof. It does a lot of changes to the body to enable you to get away from that saber-toothed tiger. And I always just say it this way, but it slows, the sympathetic input to the GI tract causes it to slow down. Because you don't want to crap your pants while you're running from a saber-toothed tiger. Versus the parasympathetic system, which is rest and digest, sitting in a beanbag neck eating Cheetos. That's the parasympathetic system. I promise you, this is building. Anything I haven't mentioned along the way, we're going to tie all this together. So if you don't know the sympathetic system's fight or flight, everything you need metabolically to be increased to get away from the saber-toothed tiger is going to happen. The parasympathetic division, like I said, rest and digest. Sitting in that beanbag. I don't own a beanbag, but think about buying it. All right, let's take a break.
Hey guys, this squad.
It's 10:45 or 20 minutes. Not quite long, like I said.
I didn't ask if I was gonna. I know there's stimulations in the heart, but we don't feel our heart, right? We don't feel anything. I remember back, it's making an international feedback, high school or whatever. They said that if we don't feel pain in our heart, so it travels somewhere else in our body. It's comfort, either our thoracic chest wall or straight down our arm. Is that right? I mean, you don't feel anything. Well, it makes sense.
No, the thing is, the reason for that, it's always referred to. It's referred to all the body.
If we touch our guts, we're not going to feel pain.
But if there's activation of the receptors in the heart area, it will, basically what happens is, the area of our left shoulder enters the same zone as the spinal cord as the fibers from the heart. So when you intense activation, the heart or the brain starts to show that pain. Even though there's nothing wrong with it, it's because they go into the same level.
That's the way they would explain it. It's like your body's like, we are experiencing some sort of something. Pain, I don't know where to put it from because it's not here. Well, it's going to go to the closest spot.
Before that, you're going to feel like
I just don't get sick because I think
you don't feel it. It's starting to ramp up where you're going.
But that's what we're talking about.
I just think that Tuesday right before
Your other arm,
I'd like to try it. Like, I keep on, I get so deterred. I don't know why I can't just sit there and stay on something.
Yeah.
Big ass freaking sandwich. You're just gonna make you fat, bro. All that cortisol and feeding you and
I'm gonna have to next week. I'm gonna have to be 50-50 with this class and micro. To be able to come in on Monday.
I took everything. I was fine for it. Like 5 people doing it so fast.
I probably won't.
Like, did you understand that? He's like, no, like, why are we doing it? And then first call was like, I was thinking the same thing. And Casey texted.
Yeah. I'm taking Saturday.
I do remember calling it the That was an A&P 2. That was an A&P 2.
Yeah. It was the sophomore class that we had the lunch room today. And like they had more office chairs and those things were frustrating. Like back there, facing in here, the back's coming off, like a lot of them sit in it. I was like, man, that's quality. They really try to shoot you nice and you know here.
I don't know how y'all get these are new. Those other ones were in there.
Okay.
You might be on the right.
Yeah.
I gave somebody once when you're thing I brought they gave me a new desk maker and I didn't need this fancy one. So I brought the old one in.
Stop at Whataburger on the way home. That sounds good. Give me a greasy burger. And take a nap. We can go golf. I'm not doing shit.
We're gonna watch Accountant 2.
Huh?
We're gonna watch Accountant 2. Remember the Accountant movie? The guy was really smart.
Oh, yeah.
Really good. Hey man, second one's out. It's free on Prime.
Yeah, did you know that you can get Disney Plus for free?
Remix.
Yeah, when you paid for, you said that it was like the worst. What was it that you said was the worst military movie?
Yeah, but that was free.
I was like, I like went home and I was like, because I also wanted. You guys watched the new Captain America? That was pretty good.
It wasn't as good.
Yeah,
Like it wasn't a
it wasn't like
story.
Yeah, it wasn't like a thriller like they normally are.
It's like they just made it to make it.
Yeah, and then it says at the end. Did you watch like after the credits? There was like a blurb. So the blurb after it's like Captain America will return.
I mean, I figured how they ended it to like get better and get your wings back. Yeah. I should have went to pee. Yeah.
Are you going to go for what is your intuition?
This might be my first one in 4 years. Big stuff is small for us. And then I was scared. Excited, like whatever. Or like, what's the reason? I know but like I'm like really scared that resort versus reabsorb, like those messing up. I've never heard of it. So like if you told me so I was like, hey, I see your hype. So like are you going over Monday sort of averages? Oh yeah. But you said
Yeah, that sounds good. I was going to draw all the home here. Good visual though. That's from
My brain is not braining right now. What's that thing that they said when you're like looking, so your brain's like phasing?
my wife was trying to get me to go buy an iPad.
I just went into like
Memory foam. Like, hey, sleep
I feel like
I'm gonna watch this. All right, here we go.
Sleep so hard.
It's Friday, so what do they say? Hold on to your britches, because this is sympathetic motor pathways. What's keeping y'all? Why are y'all still here? What's keeping y'all from leaving? Yeah, it's digression. We do the same amount of slides regardless of who they are. You know what I'm saying? I just pace it well. But we're pacing now so that next week's not as painful. We'll see later. Sympathetic system. Okay. Cell bodies are found in the lateral gray horns of T1 to L2. Back to what we talked about yesterday, or maybe 3 lumbar segments. We'll go with 2 then. So that means the preganglionic axons of those cell bodies are going to leave the spinal cord. Now we got to. Let me talk about how I set this up. It helps to know the overall organization. When we look at the spinal cord, I want to know how it got to where it's going. So we're going to start at the spinal cord, and we're going to look at what route it went through, and then we're going to go to what ganglion it got to, and then out to its effector. So we're going to discuss everything in that order, like we're walking through it. At one point, I will be walking you through it. So you have a cell body that's in a lateral gray horn. Its axon is going to leave that area. It's going to make its way out of the spinal cord using the ventral root. Correct? Because all motor fibers leave through the ventral anterior side. All right, so that's the first step. Now we have autonomic motor neurons, is what we're focusing on here, because it's sympathetic system. But what else left on that ventral root that was a motor neuron? Somatic motor neurons. Okay. So both of those are going together through that ventral root. Now they're outside of the spinal cord, and they have to go through the intervertebral foramen. So they'll come out of the ventral root, and then they'll make their way through the intervertebral foramen. That area is called the spinal nerve, because what's coming into that intervertebral foramen? The sensory. Remember, the sensory and motor are combined for a second. We tape them together real quick so they could make it through that opening. Right, we're going out. We're only looking at motor right now. So the motor's going out. All sympathetic preganglionic axons are going to be myelinated. Back to her question, it's just a fact. They are myelinated, which, means they're faster. Okay. So when we look at this crazy diagram, what it's representing, the black lines are showing us from here to here, T1 to L2 is where sympathetic output out of the spinal cord occurs. Okay, that goes all the way back to saying, well, that's why the only areas that we find lateral gray horns in the spinal cord is at T1 to L2 and S2 to S4. But the T1 to L2 portion is the sympathetic output. So I'm repeating and rephrasing. So all sympathetic output from the spinal cord originates at T1 to L2. We're going to keep going here. Those myelinated axons. Let's orientate this picture because I know it makes sense to me and not to everybody. Here is an autonomic motor axon cell body in the lateral gray horn. We're talking sympathetic system right now. We're going to do parasympathetic separate. Its axon, its myelinated axon, is going to leave through the ventral root, become part of the spinal nerve, going to go out. Now what, I'm trying to do this slow and bring y'all along with me. The autonomic motor neuron and the somatic motor neuron both were part of that spinal nerve originally, right? They came out of that hole together. The somatic neuron axon is going to keep going to its skeletal muscle. But on the sympathetic system, its autonomic motor neuron is going to take a detour. It's going to get off of the spinal nerve highway. It's going to take an exit. That exit You're visualizing the exits with me, like on the highway. The exit is going to be called the white ramus. Remember, we have rami communicante is a funny word, but you have a white ramus. Why do you think we call it the white ramus? Yeah, exactly. Thank you. It's myelinated. All right, so that's how it got off of that spinal nerve and went into an area called the sympathetic trunk. Okay, don't worry about the trunk, what it is just yet, but there's the sympathetic trunk is a group of ganglions. I'm going to extensively show you that. Right now, I just want to mention that it goes through a myelinated area called the white ramus, and it enters the sympathetic trunk. It's called the sympathetic trunk ganglion. Now, we only see white rami at what levels? I know it's on the slide. T1L2. Okay, well, why is that? I'm being very facetious as I go through this. Or deliberate, better word. Well, why do we say that? Why would we want to say white rami are only present at T1L2? Well, that's the only area of the spinal cord that sympathetic output leaves. We don't need a white ramus at C3 level. There's no output there. Am I tracking? If not, I know it's Friday. If you're not tracking, let me know. There's no output out there, so we don't need a way for that axon to get off of that spinal nerve. That's another way to say it. But in these areas, we do. Okay. So where it's going, when it goes through that white rami, where it's going is the sympathetic trunk ganglion. Now, in the sympathetic system, we have two groups of ganglia. There is the sympathetic trunk, or what's sometimes called the paravertebral ganglia. I like that name better. And then prevertebral ganglia. Because they use prevertebral, I would rather they say paravertebral. So if we look at the first one here and say, well, there's our fancy graphic as always. Paravertebral, sympathetic trunk. What you have is a collection, a chain of ganglia that go down and make like a U all the way along your spinal column. That is called the sympathetic trunk ganglia. Now we don't have a great reference in here, but we got to realize that on pictures, things look further than they are because they can't get them close enough together. The sympathetic trunk ganglia, if you were to pick up a vertebrae, the vertebrae has transverse processes. There's a process. These are your vertebrae. There's a process on each side. If you look at a cadaver, you would see that there's these little kind of circle-looking areas, ganglion, full of cell bodies, right? And they're found right here. So that picture up there circled in red, that's just the right half of that. But you have ganglion that go all the way down the spine and up the other side, right about the transverse processes. Y'all have it? You visualizing that? So when that sympathetic preganglionic axon goes through the white ramus, it enters the sympathetic trunk ganglia. Because of that, the preganglionic axons in the sympathetic system are generally very short. Well, they're always short. They don't have far to go. Because where is the ventral root coming up? Right here. Where is the ganglia? Right there. Doesn't look that way in pictures all the time, but they're very close together. So you would say all sympathetic preganglionic axons are short. But we still got to get out to our effectors, and I'll explain this even more as we go on. That means that in order to get the second, remember, autonomic systems have two neurons in sequence. You have a preganglionic and a postganglionic. So if your preganglionic axon is very short, but you still need to get out to your effector, that means the postganglionics are going to be very long in the sympathetic system. Some of this ties in more as we go. I drew that pink line there also, because I like to generalize things when I study. Or you could look at it the other way and say, when I'm looking at a test question, I love to rule things out. It's one of my favorite things. I miss paper testing because I'm marking through things. Right? I'm like, that's absolutely not right. Now I don't even have to see it anymore. And that's why I don't like computer testing. But I like generalizations. So one of the pretty true facts is that when you look at the postganglionic axons that leave the sympathetic trunk, they are generally, almost always, going to go to an organ or system above the diaphragm. So sympathetic postganglionic axons go to organs and things above the diaphragm. Just stay with me and I'll explain all this as we go. So there are a lot of sympathetic trunk ganglia, right? It goes all the way down along there. I don't care that you know how many numbered there are. And not all of them are we even going to name. We're going to look mainly at the cervical ones. So this slide's not of great value to you other than to say, yeah, there are three. There are cervical ganglia, there are thoracic ganglia, there are sacral, lumbar. Once again, it goes back to this picture and seeing the U that goes along the spine. So sympathetic preganglionic axons that go through the white ramus and then enter the sympathetic trunk, what are they looking to do? I know I'm being kind of just dumbing this down kind of sounding, but I think questions help. So what does a sympathetic preganglionic axon want to do in the sympathetic trunk? It wants to synapse with a postganglionic. Yeah, okay. So it's looking for a postganglionic. So here's what it can do. When a sympathetic preganglionic axon goes into this sympathetic trunk, it can either synapse with a postganglionic at the level it came in, or it can go up the trunk or down the trunk and synapse with a postganglionic higher or lower. Or it can do all three of those at the same time. Right? It can synapse anywhere in the trunk. Then it has to get out of the sympathetic trunk. So I'm going to say this and I'll try to follow with a question. There is also, the rami communicantes has a white ramus, but there's also a gray ramus. Right? The gray ramus means it's unmyelinated. I'll give you that. But we find that there are gray rami at every level of the spinal cord. So every level has an on-ramp back onto the spinal nerve. The white ramus, if you're driving, was our exit. Right? And then the on-ramp, to get back, you went into the sympathetic trunk, you synapsed with a postganglionic neuron. Now you need to leave. The way you're going to leave and get back on that spinal nerve to go out to your final destination is to use a gray ramus. So there's a gray ramus at all levels of the spinal cord. So think of this. I don't know why people get this confused. They ask a lot of questions about this. There are fibers that leave the sympathetic trunk. We said mostly go to things above the diaphragm. Well, let's picture your head. Is your head above your diaphragm? Yeah. Well, what ganglion in the sympathetic trunk do we think probably serves postganglionics to the head? Cervical ganglion, right? That's true. So let's say that's up by C3 level. There has to be a gray ramus because when that sympathetic preganglionic axon came into the sympathetic trunk and it went up to the cervical region, it has to have a gray ramus to get out of there. So when it synapses with that postganglionic, it's going to jump on a gray ramus and go back out to the spinal nerve and then go out to the skull. Hopefully that's starting to make sense. So if it is, I'll ask a question. If it is kind of making sense, why is there not a white ramus? If there's a gray ramus at C3, why is there not a white ramus? Yeah, because all sympathetic output leaves T1 to L2. You don't need a white ramus at C3. There's no sympathetic fibers leaving the spinal cord at that level. You're just, I'll stop there. We got it. Okay. So when you look at, I told you we're really just going to look at these cervical ganglion for where they're going and kind of as examples here. So these sympathetic preganglionic fibers that emerge from T1 to T6 ascend or go up the sympathetic trunk ganglia to synapse with neurons in the cervical ganglia. So if we looked at these, what it's saying is T1, T2, these fibers generally will go in and go up in the trunk. And there's three cervical ganglia. There's superior cervical, middle cervical, and inferior cervical. I'll show you how to remember them a little bit easier. The superior cervical is the most busy, meaning that the superior cervical ganglion has postganglionic axons that leave and go to things that are associated with the head. Can y'all visualize that on there? Just the head. Look at every one of these. All these dotted lines are unmyelinated postganglionic axons. And if you look at the superior cervical ganglion, you can learn a list, or you can realize they're all going to the head. I think almost everybody in here could go through that list right now. If I asked you, is the pineal gland in the head? You would say yes. You see the generalizations I'm making, so you don't have to study a list. The middle and the inferior are pretty similar. That the middle and inferior cervical ganglion are generally only servicing the heart. Okay, so all these fibers we see leaving here are going to the heart. Now, for my person that notices everything, is there one fiber from the superior going to the heart? Yes. I got it. Generalize it here for you. Generalize it. Right? We're not going to draw this out. We're just going to recognize the parts that I bring out of it like this to show you. The thoracic ganglion that leaves the sympathetic trunk are still going to things above the heart. It gets a little bit more confusing because it can still throw a fiber out to the heart, to the lungs, sweat glands, blood vessels, the skin, erector pylorium muscles that help the skin or hair stand up. So it's going to things, let's just say, more associated with the thorax region. Unmyelinated postganglionic axons pass through the gray ring. We're going to leave the trunk now. So we just described where things generally try to synapse in the trunk. But now we've synapsed and we want to get out of there. All postganglionic neurons are unmyelinated, so it's going to be a gray ramus. We're going to take a gray ramus back out onto the highway. Let's say we come up here and be synapsed with this neuron cell body. Our unmyelinated axon will leave and go out to its effector most times. That's the way it happens. And unfortunately for us on this great Friday afternoon, that's not the only thing that can happen. I talk about these a lot like they're options. These are not options. Somebody has mapped these out. We know the exact pathways. But I think it's better to think of them like there's an option. Like when I say a sympathetic preganglionic axon goes into the sympathetic trunk, and it either synapses there, or it goes higher or lower, it does all three of those. That sounds like it has options, right? It's not an option. That's just the way I talk about it. It's a set pathway, but we know all of those occur. Okay, so we've gotten out of the sympathetic trunk. And if we're going to things above the diaphragm, our postganglionic will go all the way out to that effector. But sometimes it doesn't. Sometimes, I'm trying to say this correctly. Let's say this. Unmyelinated postganglionic axons go through a gray ramus and make their way out back onto the spinal nerve, and they will go out to their effector. But what if they don't? What if a sympathetic preganglionic axon doesn't synapse with anything in the sympathetic trunk? It will go through it. So there are areas where the sympathetic preganglionic axon goes into the trunk, but it doesn't synapse in there at all, and it just goes right through it. When it does that, it's going to the other sympathetic trunk ganglia, which is called the prevertebral ganglia. They're still going to be very short because prevertebral ganglia, I guess the skeleton one. You have to be visual on this. The prevertebral ganglia are right here. I'm touching the vertebral bodies. So anterior to posterior, prevertebral. They're right here in front of the vertebrae. Well, that's great. Where were the sympathetic trunk ganglia? They were all back here along the back. So they're both very close, right? That's why the sympathetic preganglionics are real short. So if we don't go into the sympathetic, if we go into the sympathetic trunk and we don't synapse there, we will go to the prevertebral ganglia. Before we get, this is just a technical kind of thing. Before we get to the prevertebral ganglia, we didn't synapse. They're representing that here. This one came in. It did not synapse with a neuron, and it went right out of the sympathetic trunk, and it went to a prevertebral ganglia. Before it gets to that prevertebral ganglia, often several of them will combine, and they came up with a name for that called splanchnic nerves. You got to kind of emphasize it. Splanchnic. So people say splanchnic. That's how it's supposed to be pronounced, I think. So now you're in a prevertebral ganglia. They're anterior to the vertebral column, along with those larger abdominal organs. And so like I said, the axons are still short, the postganglionics are still going to be long, but any preganglionic, sympathetic preganglionic that synapses in the prevertebral trunk, prevertebral vertebrae will go to things below the diaphragm. So if you're still tracking that, I'll recap it anyway. That means that there are two types of sympathetic ganglions. There is the sympathetic trunk, and there is the prevertebral ganglion. If you're a sympathetic preganglionic axon, you go into the sympathetic trunk, and you synapse there and go out to an effector, that's going to go above the diaphragm. If you just go through the sympathetic trunk, go to a prevertebral, then synapse with your postganglionic, that's going to go to something below the diaphragm. So prevertebral ganglia supply things below the diaphragm. And there are several of these. I'm going to mention three. Like I said, I narrowed some of this down. There is the celiac ganglion, the superior and inferior mesenteric ganglion. The celiac ganglion generally supply things like the liver, the stomach, spleen, intestines, and you can kind of see that represented here as it goes out. Part of the small intestine, kidney there. It goes a lot of different places. When you look at superior and inferior mesenteric, when you hear mesenteric, it's always bowels. You say superior mesenteric artery, superior mesenteric vein, whatever superior mesenteric nerves, whatever that might be, they're going to the bowels in general. And so the superior mesenteric ganglia generally send postganglionic axons out to areas like the small intestine and the colon. The inferior mesenteric inferior mesenteric ganglia send things out to the rest: the colon, the rectum, the genitals, urinary bladder. Still things below the diaphragm. We're just specifically talking about those ganglia. Okay, so now we've had two things happen. What if, I got a lot of these. I see y'all starting to take deep breaths, pinching your legs to stay awake. What if a sympathetic preganglionic axon doesn't synapse in the trunk, doesn't synapse in the prevertebral? What's going to happen? It's going to go to the adrenal medulla. Y'all probably know what that is by now. But the adrenal medulla is a final stop. Right? There are no postganglionic axons actually in the adrenal medulla because the signal doesn't need to go anywhere else at this point. But postganglionic neurons, when you look at development, embryological development, are derived from what's called a chromatin cell. So chromatin cells give rise to postganglionic neurons. But in this case, we're talking about the adrenal medulla, and it's kind of special because it's just packed full of chromatin cells. And chromatin cells are where epinephrine and norepinephrine come from. This is a direct tie-in, linking this up, between the fact that the nervous system and the endocrine system control homeostasis. So this is kind of an overlap, because you got nerves stimulating the adrenal medulla to release hormone. So that's a correlation there. We're almost done for the day. Hang in there. We're getting there. I'm going to walk you through all this again right before we leave. Sympathetic preganglionic fibers may have axon collaterals. So sympathetic preganglionic axons, when they go into the sympathetic trunk, if they synapse at more than one level, how are they going to do that? They're going to have axon collateral, another part of the axon that shoots off of the main axon. So the sympathetic system is a divergent pattern. So if there are postganglionics for the sympathetic system at basically all these different levels of the sympathetic trunk, if we send a signal in there and we throw off axon collaterals, can we stimulate multiple postganglionics at once? Yes. Because of that, it's going to diverge greatly, and the sympathetic system is going to affect almost every body system at once. When you look at postganglionics of the sympathetic system, they generally will terminate at several effectors after leaving their ganglion. It spreads out greatly. I'm doing good. Okay. Let's take a second. We're going to digest all this in, and we're going to talk about it. I want you to follow on these two slides. This is a good one to draw out. I'm just going to stand up here and do you a visualization, and then we'll be done for the day. If you're not tracking at some point, or even after we get done, you're like, I still don't understand part, that's where we need to focus in on. Ask me a question before you leave. Okay. We're only talking sympathetic system right now. So I should have you close your eyes and watch yourself too. I am a preganglionic cell body of a sympathetic system. Sympathetic preganglionic neuron. My cell body is located, I'm not going to ask, I'll ask some questions as we go. My cell body is located in the lateral gray horns of T1 to L2. I heard all the answers. I just say it. So I'm in there. I'm gonna take a walk. I'm going to go out to my effector, whatever that might be. So I'm going to leave the spinal cord by getting on the ventral root, going onto the spinal nerve. And then I'm going to go down the spinal nerve highway there, and I'm going to exit. What am I going to exit on? White ramus, because I'm myelinated. I look like the Goodyear blimp guy. I'm myelinated. I'm walking. I'm going to take that exit. Now I'm in the sympathetic trunk. At this point, we don't have choices. It's math, and I'm going to give you choices. At this point, I have a choice, and I'm going to decide which postganglionic axon I like the best. So I come into the sympathetic trunk. I can synapse at the same level I come in and, hey, glad to meet you, I like this postganglionic neuron, I'm going to synapse here. Or I can go up to the top of the trunk, or I can go down to the bottom of the trunk, or I can synapse with more. Maybe I like all the people in here, all the postganglionics. I can synapse. Okay. If I synapse with one of them, if I synapse with a postganglionic that's in the trunk, I'm going to immediately leave the sympathetic trunk through a gray ramus at whatever level that might be, and I'm unmyelinated, and I'm going to go all the way out to my effector, which is going to be something above the diaphragm. Okay. Now let's back up. I got to start kind of at the beginning. If you're tracking, or if you're not tracking, let me know. I'm a sympathetic preganglionic axon leaving the spinal cord. I go into the sympathetic trunk. I look around, and I see all these post-ganglionic cell bodies, because it is a ganglion. And unlike the last time, I don't like any of them. Matter of fact, these post-ganglionics are not even people I would have a barbecue with. So I'm not going to synapse with any of them. I'm going to leave the sympathetic trunk and say, forget it, I'm going to try my chances better down the road. Where am I going? Prevertebral ganglia. I went right through the trunk. Do I still look like the Michelin man? Yeah.
Yes.
Why do I still look like the Michelin man?
Yes.
Because you haven't synapsed yet. You will be myelinated until you synapse. So I went right through the trunk. Okay, now I'm at a prevertebral ganglia. I like prevertebral ganglia, postganglionic people, so I decided to synapse there. I'm going to leave the prevertebral ganglia, and I'm going to go to my effector, and I'm unmyelinated at that point, right? Because I did synapse. I'm the postganglionic. And in that case, I definitely went to something below the diaphragm. Okay. So now we got to start over again. There's several different ways here. Now here's the other one. I'm a sympathetic preganglionic axon. I leave the spinal cord, but the ventral root. I go into the sympathetic trunk. I look up and down. I don't like any of the postganglionics in here, so I'm not going to synapse in the trunk. I'm going to keep my myelination, and I'm going to go to the prevertebral ganglia. I get into the prevertebral ganglia, and like a lot of times in my life, I look around and go, I don't really like them either. So I decide I'm not going to synapse in the prevertebral either. I'm going to be difficult. So I'm going to take my chances and say, well, let's see what the next location has to offer. In that case, I leave the prevertebral ganglia. I have not synapsed yet, so I am still myelinated. And where do I wind up? The adrenal medulla, which is a clump of chromaffin cells that are precursors to postganglionic neurons. So you can think of the adrenal medulla as a clump of postganglionic neurons that release norepinephrine and epinephrine. That is the whole sympathetic pathway we just talked about for the last 40 minutes in an analogy kind of visual. If you're following and tracking that, you're getting it. Okay? So most of y'all, I was getting a lot of replies back. So I've done that before and had complete silence in the room. And now don't come back to me when you're asking questions. Stop thinking about it. You take the visual and then you get the real thing. I gotta say it for the third time. When I got into the sympathetic trunk originally, did I have options? No. These are map paths. I get that question all the time. People come up and say, okay, so what if I choose to do this? Great. We're not choosing. It's a mapped pathway. You know what I mean? So hopefully y'all don't feel, actually I'll ask y'all, but did it feel like for a Friday that you somewhat got it? Or are you really like just playing me and like, I don't have a clue what you're talking about? You don't have to answer. I can look at reactions. I think some of y'all got it. Some of y'all are ready for me to stop talking. Yes?
More of a semantics question, but talking about outflow from spinal cord in the area, why is part of the vertebral ganglion flowing from the vertebral to that area?
Because it's the location. Because it's located. That's why I'm going all the way. He's talking about prevertebral, but if you left the vertebral area to get there, why do they call it that? It's because they're looking at their location. Remember when we had the sympathetic trunk ganglia, there's sympathetic trunk, or there's sympathetic ganglia, then there's sympathetic trunk ganglia, and prevertebral. That goes all the way back to what I said in the beginning. They should just keep calling it what its other name is, the paravertebral. Because you're giving the location of one and not the that's the way my mind works. So, makes sense. Just because where they're located. All right, anything else before we go? I know y'all aren't going to be looking at this in depth this weekend. You should somewhat, though. I mean, at least.
I'll be the next step.
Oh, you have nothing Monday?
Nope.
Oh, I didn't know it was that important. All right. What do you need to know about cranial nerves then? Everything.
Where are the periods?
I want you to be disappointed in my question when you get to cranial nerves. I want you to go, come on, give me something harder than that. All right? I didn't mean that as a challenge. People take things like that. Y'all have a good weekend. Stay safe.